I'm delighted to introduce Dost Unger, who's our next speaker. He's a native of Istanbul, Turkey, and is the William P. and Henry B. Test Professor of Psychiatry at Harvard Medical School and Chief of the Division Psychotic Disorders at McLean Hospital. He is the editor-in-chief of JAMA Psych, doing a fantastic job. Has pushed the citation index to, I think, over 25, which is incredibly high, and we appreciate his efforts in doing that for the field. He receives funding from the National Institute of Mental Health, other sources for his research on the clinical manifestations and neurobiology of schizophrenia and bipolar disorder. And he's going to be talking to us about assessment and treatment of suicidal thoughts and behaviors in psychotic patients. Dost.
Thanks very much, Dr. Schatzberg. Good afternoon to all of you. It's great to be with you. As I'm pulling up my slides, I also just want to address an issue that came up earlier in the conversation in relation to psilocybin and psychotic disorders. As Dr. Schatzberg said in response to that question, it's really an open question. There's not a lot of research in that population, and most ongoing clinical trials are excluding people with psychotic disorders from psilocybin use administration. What I can tell you is that at our hospital, we're already seeing patients who are vulnerable to psychosis, either having a history of psychotic disorders or being a first degree relative of someone with a psychotic disorder. If they are exposed to psychedelics, they actually are at risk of psychotic episodes. So we're seeing people hospitalized with psychotic episodes in that context. So I think there's more to come there. The clinical trials are very clear that psychedelics are promising treatments for depression and potentially suicidality. But I think there's going to be vulnerable populations where we're going to need to avoid exposing people to greater risk. Okay, coming back to my presentation on suicide assessment and treatment in psychotic disorders. This is my disclosure slide. I have received honoraria from 2 companies for scientific presentations. And as Dr. Schatzberg said, I received funding from federal government as well as other foundations and so on. So, of course, some of the things I'm going to say are going to be picking up themes that already have been mentioned earlier in the day. There's no doubt suicide is a major public health challenge. It's been worsening in the U.S. in recent decades. Psychiatric disorders constitute a major risk factor. And this is also true for psychotic disorders specifically. And by psychotic disorders, I'm referring primarily to things like schizophrenia, schizoaffective disorder, and some of the less common related conditions. And for completed suicides, a few things often used to have to come together. Those include underlying psychopathology, the acute psychic pain that we've been hearing about, and access to lethal means. And again, in psychotic disorders, these are all present in many situations. This is data from the CDC. I just wanted to throw it in here as a visual representation that, in fact, suicides have been rising in the United States in recent decades. There was actually a dip with the pandemic in 2020, interestingly enough. But unfortunately, after 2020, the increase in suicides has resumed its previous trend. So these numbers are high, and they're higher than they have been in living memory. In schizophrenia separately, the actual proportion of patients with schizophrenia who die by suicide has been debated. This is a very careful study that looked at a number of papers. It's almost 20 years old now, but they estimated that 4.9 or roughly 5% of people with schizophrenia will commit suicide during their lifetimes. So this is 1 out of 20 patients, and this is actually one of the lowest estimates. Some estimates are higher and closer to 10%. This is a big deal. And those of you who work with people with schizophrenia probably know more than a person or two who have died by suicide like I do. It's just a fact of life that people with schizophrenia are at very high risk. And if you follow them over a few years, you will definitely experience this. So this is just a big reality that psychotic disorders clinicians need to be aware of. So Suicide and psychosis is common and highly dangerous. The suicidal ideation and behavior, I should say, is common and highly dangerous. Assessment and treatment of suicidal thoughts and behaviors in patients with psychosis can be challenging due to the complex interplay of psychopathology. And what I mean by that is that people with psychotic disorders who are at risk for suicide don't necessarily come in and say, I'm thinking of killing myself. Depression is not a necessary factor, and we'll go into the risk factors in a minute. And suicidal presentations are not necessarily the norm, but there's a lot of complex psychopathology that can actually increase the risk of suicide, and clinicians need to be aware of that. And so it's really crucial to assess both psychosis, that's psychotic symptoms, psychotic experiences, and risk factors, as well as suicidal ideation and behavior simultaneously. So clinicians who work with psychotic disorder patients really need to be on their toes about who might be at risk of psychosis. So I'm going to go through the risk factors a little bit, and I've grouped them in ways that sort of tell a story. So on this slide, you have what might be called the loss narrative risk factors. So among people with psychotic disorders like schizophrenia, those who are in younger ages, early course of illness, especially the first decade, with partial insight, high educational attainment, good premorbid functioning, people who were doing well before they got sick, and also poor current work and school functioning, poor community functioning. So these risk factors taken together, what they're saying, as I said, is a narrative of loss. Young people who had much to lose, who are then stricken by a major psychotic illness, who are unable to go back to work or school, who have some understanding that they have a major problem in their lives and that it's unlikely that they will recover all the way back to the way their life was before they got sick. Those are the people that are at highest risk of suicide. Because, of course, in this case, what this means is that the individual is grappling with losing so much and not having much hope that there's going to be recovery. Now, this isn't actually the reality of psychotic disorders, because many people with psychotic disorders do recover very well and can have meaningful, fulfilling lives. But of course, the reality also is that these are major challenges to people's well-being. So we just have to be, sort of able to hold both sides of that. But for the young person, the 19, 20, 25-year-old who has been unable to recover from their illness and feels like there's no hope, that's a high risk for suicide. And this very first bullet point, by the way, is also one of the reasons why the estimates of suicide vary. In some studies, researchers will follow a group of young people with schizophrenia for, let's say, 5 or 10 years, look at how many people die by suicide, and then extrapolate that out to a lifetime. And if you do that, you end up with higher estimates, like 10% or even 20%. But what you're missing then is that in later decades of life, the risk of suicide in schizophrenia does go down. So it's good to be mindful that the majority of suicides actually happen in the early phases of illness. The second group of risk factors are about the clinical features of the illness and treatment. So poor treatment adherence is a risk factor. Symptom severity is a risk factor. And among the symptoms, a couple of big ones are command auditory hallucinations. So these are people who are hearing voices, and the voices are telling the person to hurt themselves. This is a major risk factor. And when you as a clinician hear somebody complaining of this, you have to be on guard. This is a very high risk. It's difficult sometimes for people who don't have this experience day to day to relate to our patient population, who may be experiencing it in the course of the day. They're just trying to get on with their day, but they hear relentless voices, sometimes with great meaning behind them. For example, people you may know, past, dead family members or other people important in your life, or even, people, voices that you think are the voice of Satan or God and so on, telling you you're worthless. You've never accomplished anything in your life. You're a burden to society. Everybody hates you. Dying is the only option. Why do you keep going? If this is what you're experiencing all day long, it's very difficult to fight against it. And this makes it a very big risk factor. Also, delusions eliciting guilt and shame. Many of our patients with psychotic disorders struggle with delusions about being responsible for death and destruction, or being contaminated somehow, being dysfunctional somehow. That elicits a natural psychological reaction if you truly believe that you have harmed somebody else without wanting to, and that's a burden you're carrying. This actually raises the risk of suicide. So, like I said, the psychopathology of psychotic disorders actually is complex. These patients don't necessarily come in and say, I think I will kill myself, or I'm thinking about suicide. But they might come in and report these psychotic symptoms, and the clinician needs to be aware of that. The effect of negative symptoms is controversial. There are some studies that have suggested that negative symptoms are actually protective. And by negative symptoms in psychosis, we refer to things like lack of social drive, lack of motivation, not much production of thought and speech. So people who are withdrawn, people who are not very active in society. And this may be protective because you don't have the energy or the wherewithal to plan a suicide or complete a suicide. But some other studies have actually not found that. So that's an open question. But there's no doubt that the hallucinations and delusions are a risk factor. And I also want to highlight a medication side effect, because we don't think about this often enough. Many of our patients are, of course, on antipsychotic medications. That's the first line treatment for these conditions. But one of the side effects of antipsychotic medications is something called akathisia. Akathisia refers to a subjective sense of restlessness that's relieved by physical activity, getting up and walking around. But this can actually become quite unbearable for some people. If you are familiar with restless leg syndrome, for example, when you're falling asleep and you have this intrusive sensation that you need to move your legs, think about that all day long, having to get up and walk around and never being able to get comfortable. Akathisia actually leads to a greater psychic pain, psychological pain, as we've been talking about. And that's just a medication side effect that we need to be aware of. And so when people come in and are talking about agitation and inability to tolerate going through their day, ask about akathisia-like symptoms. And the last grouping of risk factors is what I would call kind of social and environmental risk factors. Men who are unmarried, living alone, unemployed, recent life events such as loss, losing family members, losing jobs, and so on, recent discharge from the hospital. This is actually an important point. Hospital discharge is an important risk factor for suicide. For many of our patients, it's difficult for them to settle into a daily routine. And if that routine has been disrupted, and now you come out of the hospital after having been there for maybe a week or 2 or 3, and bills need to be paid, dishes need to be washed, family members or friends are wondering, where have you been? And you just don't feel like explaining yourself to people. This is actually a big burden. And there's a blip in completed suicides in patients who've been recently discharged from the hospital. And finally, access to lethal means such as firearms. There's no doubt that if you're feeling suicidal and you have a gun sitting in a drawer in your house, the impulse of going to grab that gun and hurt yourself is much easier than if you're feeling suicidal, but there is no easy access to fatal means of hurting yourself. Assessment. So some of these themes are now going to be very similar to what we talked about earlier in the day. Of course, any mental health clinician needs to conduct a comprehensive evaluation. You want to go through the patient's mental health, detailed history of their psychotic symptoms, suicidal thoughts and behaviors, underlying factors contributing to their distress. Risk assessment using standardized tools. They're out there, and we've already talked about them today. Consider factors such as intent, plan, and access to lethal means. Just like we say, every clinician needs to ask about suicide every time. You also ask about access to lethal means. Do you have a gun in the house? Or do you have access to a gun or some other lethal means? Clinical interview, supportive and empathetic interview to establish rapport, gain insights into the patient's experience, ensure that the patient feels heard and validated, and also related to this, hopeful. As I've been saying, some of the risk factors for suicide and psychotic disorders are about demoralization and loss of hope. And the interview with a mental health clinician can go a long way to actually restore that hope. And you want to be giving people this notion that with good treatment, many people will do well, and you're not going to stay this way forever. I know you're feeling very difficult things right now, and it feels intolerable, but there's light at the end of the tunnel. Collaborative care is important. Multidisciplinary teams, including psychiatrists, psychologists, social workers, and other professionals as needed, need to be involved in the assessment. This is typically a high-risk patient with schizophrenia is not somebody who should be seen in a sole practitioner's office. There needs to be a team of people who are thinking about that patient, because the outcomes will be better then. Differential diagnosis, you want to be thinking, is this schizophrenia or schizoaffective disorder, or is there bipolar disorder or depression with psychotic features? Is there substance use? These may contribute to suicidal ideation, and you want to be aware of them. What about treatment principles? Of course, I mentioned first-line medications for psychotic disorders. Antipsychotic medications are also important in management of suicide. Minimize side effects, be aware of akathisia, consider clozapine or lithium if appropriate. We already heard about this earlier today too, and I'm going to come back to this in a minute. I'll dig in just a little bit, one slide each for clozapine, lithium, and ECT. Psychotherapy, evidence-based psychotherapies like cognitive behavioral therapy, dialectical behavioral therapy for people who are impulsive and at risk that way can help address psychotic and suicidal symptoms. Safety planning, develop a safety plan with the patient and caregivers, identify triggers, warning signs, coping strategies, emergency contacts. Crisis intervention, ensure the patient knows how to access crisis intervention, including hotlines, crisis centers, emergency services. We talked about this earlier today too. Family and social support, involve the patient's family and support system to provide assistance and encouragement. Psychoeducation, provide the patient and family with information about psychosis, suicidal ideation, and available treatments. Continuity of care, collaborative care, the team-based care that I already mentioned. The name of the game in psychotic disorders, high-risk psychosis patients, is multiple people worrying about the patient over time and intervening to make sure that the risk is being managed and mitigated. And don't forget the patient's cultural background and beliefs, because these can play a major role. And if you're not asking about the patient's understanding of their own psychosis, of the problems that they're experiencing, or of suicide and suicidal ideation and behavior, you may miss important details that are going to be helpful clinically. As I said, just a few slides about three specific treatment interventions. These slides are actually courtesy of Dr. Ross Baldessarini, who presented last year on treatments for suicide. Clozapine has FDA indication, as Dr. Schatzberg mentioned, and there's good meta-analytic evidence that people with psychotic disorders who are on clozapine have lower risk of dying by suicide than people with psychotic disorders who are not on clozapine. This is probably not because clozapine has any special anti-suicidal potion inside it, but clozapine is an effective antipsychotic medication that reduces multiple risk factors, including those symptoms, as well as substance use, risk of violence, and other things, and that actually contributes to better outcomes in psychotic disorders. Lithium, likewise, there is good evidence that lithium is protective against suicide. There is some recent confusion about this because there was a clinical trial that did not find that lithium was protective. But, any one study can have many potential explanations. So there's different issues about that study that we can discuss. But when you look across multiple studies like Dr. Baldessarini did here, lithium is clearly protective against suicide and suicide attempts in people with mood disorders. And finally, ECT, our recent analysis last year found that people with depression who are getting ECT have about half the risk of dying by suicide than people with depression who are not getting ECT. They're getting all other treatments. Of course, there's many reasons why this might happen. And also depression is a complicated term. There are some people with psychotic disorders in this depression category, including bipolar disorder, but also schizoaffective and others. So, and why do some people go to ECT and other people don't? You can discuss, it's sort of selected by severity. So you can discuss these things. But the fact remains that if you go to ECT, you have a lower risk of dying from suicide in these analyses. Finally, I want to make a point about real-world outcomes. There's some fascinating data that has been coming out in other countries in recent years. And the punchline, I'll give it to you ahead of time, is that it's possible to reduce the number of suicides in a population of individuals with psychotic disorders. So the research translates to the real world. And the way we know that is from studies like this. This one is from Denmark. They're actually following people with psychotic disorders from year 0 when they first got diagnosed. And you see 3 curves in each of these panels, and notice the bottom right panel is about suicide. So the y-axis here is % of people who died by suicide. The green line is people who are getting routine care, nothing special. The red line was a clinical trial where they got team-based care. The orange line is the real-world outcome from thousands of patients with psychotic disorders in the country of Denmark, followed up for 20 years. You can see how it goes out to 20 years. And you can see that if you get routine treatment, closer to 3% of people are going to die by suicide in the course of 20 years. And if you're getting the team-based specialized treatment that I've been talking about, in the real world, this is not research. This is just patients showing up at clinics, and you're following them along and seeing how they're doing. Closer to 2% are going to die by suicide. So it's in fact possible to bend the needle with good team-based care. This is quite literally saving lives of people with psychotic disorders if they're getting good care. Okay. So in conclusion, I want to leave you with the messages that suicidal ideation and behaviors are common, potentially dangerous in psychotic disorders. This is not a problem of depression. Suicide, in other words, is not limited to people with depression. In psychotic disorders, it's basically about as common as it is in depressive disorders. Clinicians need to take it seriously. Clinicians need to be aware of risk factors so you can identify patients who are high risk and intervene. And the way to intervene is by providing good clinical care. We've been hearing it all day. Conduct a thorough assessment, ensure team-based care, make sure the patient and family are educated properly, make sure they're on all the right first-line treatments, make sure side effects have been minimized. And when the patient is receiving good care, the odds of dying from suicide will in fact be shorter, will be lower. Okay, I'll leave you with an aerial view of McLean Hospital, where I work. This is, of course, in the summer. In the winter, it doesn't look this nice. But since we're based at McLean, I just wanted to say thank you with this last slide.
Joe's terrific job. Not surprisingly, we have a lot of questions that have come in for you during your talk. Let's tackle a few of those right now. Is the information you provided mostly relevant to adult patients?
Child and adolescent versus adult psychiatry is becoming a bit of an artificial distinction. This break at age 18 or 21, depending on how you do it, makes it look like there's some kind of natural transition, when in reality, psychotic disorders often begin prior to age 18. Many of the studies in first episode psychosis, for example, start following individuals at age 15 or sometimes even 12. So a lot of what I said about early phases of psychosis includes children and adolescents as well as adults. And schizophrenia is less common among children and adolescents, but it's not unheard of. It certainly happens. And those individuals are at just as high risk of suicide as adults with schizophrenia.
How much do common myths, beliefs, and stigma about psychotic disorders contribute to the loss narrative risk factors?
This is something, if you work with psychotic disorder patients, that you see all the time. When people hear words like schizophrenia, schizoaffective disorder, or even psychosis, and they go home and Google it, and they watch a clip on YouTube, and they become convinced that it's a death sentence, that their life is over, they're never going to recover, they're never going to be able to do well. And then we spend a lot of time trying to educate people that this is a major problem. You can't minimize it. You can't be a Pollyanna about it. But actually, it's not a uniformly poor outcome illness. There are many people with schizophrenia who are working, living independently, and are happy with their lives. This is a big challenge. Society is talking about mental health more than ever before. And it's almost become fashionable to say, oh, I'm, so depressed and so anxious and I got to go see my therapist. These are things that are entering sort of the day-to-day conversation. But psychotic disorders, things like schizophrenia, still have a lot of stigma associated with them. The idea is that if you have schizophrenia, your life is over. You're never going to have a normal life again. And that's actually a stigma that we need to continue fighting. And just as the question is suggesting, some people who are diagnosed with a psychotic disorder like schizophrenia, get messages from society that being dead is actually better off than living with this condition, and it's just not true.
Let me ask you this for one of our viewers. When you mention exposure to psychedelics can lead to psychosis, do microdoses of psychedelics to aid in mental health symptoms also play a role in the increase of psychosis?
So that's a great question. We don't really know the answer. The problem, there's some epidemiology that suggests that, again, people who are vulnerable to psychosis, whether they themselves have had psychosis or have a family member with it, they're at higher risk of developing psychosis if they are taking psychedelics. That's true. But why are they drawn to psychedelics? Some people may already have some kind of disturbance. There was an emerging psychosis already, and they are taking psychedelics because their behavior is dysregulated, they're impulsive, they're looking for substances to change their mental state, and that's why they're using the substances. So creating the causal relationship and saying psychedelics are causing psychosis is actually not possible with the evidence that we have right now. What I can tell you is when you see people, especially young people, who seem unstable, they're not doing well, they have psychiatric problems, and they're using a lot of psychedelics, those people are asking for trouble.
It's a broad question, but it's a great one. Is there something you wish that every mental health professional knew about identifying suicidality in patients with psychotic symptoms?
Well, I think there's no one thing, that's going to crack the case wide open, as they say, and you're going to say, now I know. But what I would say is what I emphasized in the talk. You need to be aware of the risk factors, and you need to be aware of these different sort of groupings of things. So once you do that, because, caring for psychotic disorder patients is a longitudinal proposition. Most of those folks are going to be in your care for years, not months. And as you get to know somebody, you're going to know what they're like. You're going to know when they're doing well. And then when you identify that they're not doing well, whether it's a side effect, whether it's a substance, whether it's an exacerbation, you need to know when they're at high risk of suicide. And you do that by knowing the literature and by knowing the risk factors. That would be my message.
Okay, let's see here. What does the data say about which countries currently have the best systems of care for people experiencing psychosis, and why are they being so successful?
So that's an easy one. It's actually Western Europe, and within Western Europe, particularly the Nordic countries, Scandinavia. In those countries, they have nationalized healthcare, and patients don't have to worry about paying for their care or finding a therapist that takes your insurance, or only being able to go to your partial program for a week and then your insurance stops paying, and so on and so forth. There's an integrated care system. So I visited Denmark not too long ago, and I was amazed to find out when one individual is diagnosed with a psychotic disorder for the first time, there's about 20 caseworkers that can become involved. There's somebody who's a homelessness expert. There's somebody who's a food security expert. There's somebody who's a family therapist. There's, of course, the doctor prescribing the medications. There's somebody who makes sure that, you have access to a hospital or a day program or something else if you need it, and on and on. So it's wraparound care, and it's being provided by society. And of course, the reality is, in Denmark, taxpayers are paying for that, but actually taxpayers come out ahead. Because when you pay for these services to take care of somebody before they get sick, you're preventing hospitalizations, you're preventing ED visits, you're preventing disability, and society actually comes out ahead. So Nordic countries, Denmark, Sweden, Norway, Finland have some of the best outcomes.
Should we always consider inpatient care as the most important action for patients who are suicidal?
That's a complicated one. Because scenarios vary so greatly, it's really difficult to say. What I say to patients and families is we got to get you to a safe place when there's a suicidal crisis. Of course, frequently that means emergency room and hospital, but it doesn't have to. Depending on how well you know the patient, how well you know their social system, their history. Somebody who's chronically suicidal, it doesn't serve them well to hospitalize them every time they mention suicide. But somebody who's never been suicidal, and now there are some risk factors piling up, and they mention that they wish they were dead, that's somebody you worry about, and maybe you want to get them into the hospital. So it's really not possible to say, if you're concerned about suicide, hospitalize them, but it's got to be one of the major tools that's available. And, this is, it's very sad, but true. There's no such thing as a suicidal crisis that lasts forever. The key is staying alive so that you can get through it. And when patients die from suicide, you have to think of whether that was preventable. That doesn't mean that an individual clinician should have prevented it, but that as a system, are we doing enough for our patients?
Viewer would like you to speak to patients with psychosis being able to effectively learn and use DBT and CBT skills.
So, yeah, that's a good question. There's some evidence base for both DBT and CBT in psychotic disorders, but for specific indications. I kind of made passing reference to the DBT side in my talk. DBT in psychosis, it has been used primarily for impulsivity and affect tolerance. Patients who tend to be irritable or impulsive and are not able to tolerate their own experiences may benefit from DBT. Of course, it's not about borderline personality in this case. It's sort of taking the principles of DBT and applying them in psychotic disorders. There is such a thing as CBTP, which stands for CBT for psychosis. And CBTP also has an evidence base behind it. It's most effective for patients who are relatively cognitively preserved so that they can examine and label their experiences as abnormal. So a patient who can say, I'm hearing voices again and I need to get this under control. Or a patient who can say, I'm having delusional thinking, I keep having these ideas that Satan's out to get me, and I'm fighting it. I'm trying not to have them. That's a great patient for CBT because they can actually work on those issues, those experiences, and when things are happening, they know it. Unfortunately, the majority of people with psychotic disorders actually are not able to do this. Cognitive abnormalities are common in psychotic disorders, and they lead to a loss of insight. So if a patient is not able to say, well, that voice is not real, and I need to work on not following it. Instead, they're really listening to it and believing it. CBT doesn't help very much. So the effect sizes in studies that have been done are actually relatively modest.
Let me squeeze in one more question, Dost. Would you please speak to lethal means as that term relates to medication? Most of my clients are on medication, and many of my clients historically consider overdosing on their medications as a means to end their life. How can we evaluate for these patients?
Yeah, great question. It varies from medication to medication. Medication overdoses, of course, this is now broader than psychotic disorders. Medication overdoses are a very common, in fact, modal way of suicide attempts, but they actually account for a relatively small proportion of completed suicides. And the reason for that is because many medication overdoses are not fatal. The ones that are fatal depend on, the type of the medication, the dose that's taken, and also the odds of being rescued. And those vary from scenario to scenario. One big one to worry about is lithium, because lithium overdoses can be fatal. And there's a whole sort of, progression. Some patients who end up in the ED after a lithium overdose might end up actually getting dialysis to remove the lithium from their system. That's how dangerous lithium can be. So, that's a big one. Second generation antipsychotics and SSRI antidepressants, they're not safe by any means, but they have a lower index of fatality. So they are somewhat safer than lithium when it comes to overdoses and suicide. That doesn't mean you should have a false sense of security. You want to evaluate each of these on their own, but they actually can be tolerated a little bit more. Patients that you're worried about, things to consider: don't write 90-day prescriptions, consider 30-day prescriptions. If there's unusual behaviors like requesting refills early or frequent claims, I lost my medication, can you send it in again? Should make one concerned that there might be hoarding going on of the medication, thinking that the person is, going to have more medication available when they want to overdose. Or of course, any concerns about non-adherence. Somebody who hasn't been taking their medication, but they've been filling their medication, may now have extra available. So those are all warning signs that you need to consider.
Dost, I wish we had more time. So many questions still unanswered, but we'll have to circle back to these another time. Thank you so much for your time with us today.